So I'm going to talk about difficult ventilation. So this, of course, I'm not going to go through. This is a definition everybody knows, so really don't talk about. And that basically is the definition of severe ARDS. So, but if you want to have a little more qualified, a little more, some people say that just the PEEP might conform the so-called PF ratio. So some people have proposed that you use this P by FP ratio, which is PO2 by 10 divided by PO2 into PEEP. And again, a P by FP less than 100 defines severe ARDS or refractory ARDS. And if you're using pulse oximetry at the bedside, you can also use a pulse oximetry to FI2 ratio. So the pulse oximetry by saturation by FI2 ratio of less than 90 supposed to approximate severe ARDS. Now these are all the things that can be used in the management of ARDS. I will talk about some of them. I'm going to talk mainly about the ventilatory strategies for the management of. Of course, this everybody knows. I really won't dwell too much about low tidal volume ventilation because your priority in ARDS is not merely to get normal oxygenation. Your priority really is to protect the lung. And any ventilation done, no matter how well, will always cause some lung damage. So your priority really is to minimize the lung damage and not merely aim for normal blood gases. That is probably the single biggest mistake we all do, trying to aim for normal gases at the expense of lung damage. This everybody knows, so I really won't talk about. And remember, in the exam, they'll ask you that it is predicted body weight, so you need to mug up this formula one day before the exam because you'll forget after that anyway. So, and of course, the most important thing is individualized PEEP titration. So now, why do we have PEEP? Of course, we know there's going to be collapsed alveoli, so you need to open up this collapsed alveoli. At the same time, when you give PEEP to open up this alveoli, there's a sort of normal lung at the top, and when you give PEEP, you're going to overdistend this normal alveoli. So the best PEEP is this balance between opening up of the collapse, because once you open up the alveoli, obviously you're going to improve ventilation. But if you do too much, then you're going to ultimately overdistend the normal alveoli. So it's difficult. You basically need to decide which is the best balance between overdistension on one hand and opening up of collapse of the alveoli on the other hand. So there are lots of strategies. People thought in the past that we had this ARDS it's called the idiot's guide to setting a PEEP, that you just look at the table and you just look at the. But if you look at that, they were using PEEP as high as 25, 30 in the old ARDS trial. Higher the FI2 required, the higher the PEEP. That is their logic, and they went up to these kind of PEEP. But nowadays nobody uses these kind of PEEPs because there's a lot of hemodynamic disturbance, especially the RV gets affected when you use such high PEEP. By and large, when you talk about high PEEP, we're talking about up to 16, not beyond that, and low PEEP is less than 10. Nobody goes up to these levels because clearly affects the RV function. So, but in any case, there have been 3 studies which compared a low PEEP strategy, 3 major studies. A low PEEP strategy, but a low PEEP meaning generally PEEP less than 10, high PEEP means generally up to 15, 16 average. The alveolar study, which is part of the oxygenate trial, the lung open ventilation study, and the expiratory express study. So over 2,000 patients in all. And all these 3 studies basically did not show any difference in outcomes, whether you use low PEEP or high PEEP. So on the basis of these 3 studies, we have the recent ES-ICM guidelines. They clearly admitted that they can't make a recommendation. They just said that they gave up. They said you can use high PEEP, low PEEP. It doesn't matter because on the basis of these 3 studies, they said no recommendation, high level of evidence of no effect. They have said the evidence says there is no effect of whether you use high PEEP or low PEEP. But then there was a meta-analysis of these 2,000 patients, which this together were 2,300 patients nearly, and they show that in the group which has most severe ARDS, not all ARDS, the group that most severe ARDS, there was some indication that maybe high PEEP worked. Only in the group, in patients with mild or moderate ARDS, probably actually, mild ARDS definitely, high PEEP actually did more harm than good. But in severe ARDS, maybe high PEEP worked. So therefore, the Americans are a little more pragmatic, said that we suggest using higher PEEP but without recruitment management. We'll talk about recruitment later. In patients with moderate to severe ARDS, again, not in mild ARDS, and this is a conditional recommendation, low to moderate certainty on the basis of these so-called trials. Now, why is it that 3 major trials did not show any improvement between high PEEP versus low PEEP? That is in fact probably part of almost every trial in critical care nowadays. Almost all of them are negative trials. Why is that so? Because what happens if you look at this is an original study done by Gattinoni several years ago, that not everybody in ARDS is the same. They differ because some patients have a lot of recruitable lung. In those people, using PEEP will help because when you are going to open up the lung. But many patients with ARDS do not have much of recruitable lung. In fact, if you look at the percentage varies from up to say 30%, 40% to nothing. So if you use a high PEEP in patients who do not have recruitable lung, you are only going to open up the normal lung and cause more harm than good. Now, when you lump all these people together in a trial, The ones in whom PEEP does good is going to be offset by the ones in whom PEEP does harm, and ultimately have a negative triad. It's like giving steroids to patients with sepsis. Steroids does good in patients who are hyperinflammatory, but might do harm in somebody where patients are immunosuppressed. And you combine all of them. So, a priori, actually, before the trial, you should try and find out who are the people who are likely to have a recruitable lung. These are the people who are likely to improve to with a high PEEP. Other people do not have a recruitable lung. There's no point in using high PEEP in them because it's not going to do any good. It's only going to do harm. So basically, therefore, before you try and use a high PEEP strategy, you should try and identify at the bedside, do they have recruitable lung? Now that is really is the big problem, because the only ideal way of finding out recruitable lung is to give them PEEP and take them to a CT scanner, give them PEEP and see what happened to lung. But it's not possible or practical to shift every ICU patient to the scanner back and forth. A lot of ICUs in Italy have CT scanners by the bedside. Maybe that's why they can publish all the papers. But for us, it's not possible to actually do titration. So you have to have some other way of finding out whether lung is recruitable, whether you can open that lung with high PEEP or not. So that's the issue. So like I said, at least you should think, so clearly some people say that early ARDS is likely to be more, these are all hard and fast rules, but early ARDS is more likely to be recruitable, more severe ARDS more likely to be recruitable, ARDS due to sepsis is more likely to be recruitable than ARDS due to pneumonia. These are all not hard and fast rules. Ultimately, there is no 100% way of saying whose lung is likely to be recruitable, whose lung is not likely. You have to have some sort of other ways. So basically, how can you do? You can look at the oxygen response. Some people say that by increasing the PEEP, if the PF ratio increases by more than 25, maybe it indicates recruitability. PF ratio increasing by more than 25 when you use a PEEP. The drying pressure changes. When you use a higher PEEP, the drying pressure reduces. It probably means improving lung compliance. Maybe these situations patients are recruitable. Then there's something called a recruitment inflation ratio, which is just being developed. So that's one more possibility. Then there's something about phenotypes, which I'll talk about. There is electrical impedance tomography, which is obviously very expensive, not available in most ICUs of the country. These are things that may help you decide who is recruitable, who is not. So ultimately, basically, the whole problem is that we don't know who. We need to have a better idea. Most of us tend to look at either compliance or improvement. Such one of the two we decide whether it's patient. But what I'm saying is, if by giving a PEEP, higher PEEP, there is either no improvement in compliance or no improvement in oxygenation, maybe you should back off and come back to a low PEEP. Only in patients where you find there's an improvement, these people are likely to have recruitable lung, then you should try and use a higher PEEP strategy. Don't blindly use high PEEP for everybody with severe ARDS. And there's a study going on which is looking at mechanics and then deciding about high PEEP. The result is not yet available. The bit about inflammatory phenotypes, because basically this looked at two kinds of phenotypes in ARDS: a pro-inflammatory phenotype versus a anti or low inflammatory phenotype. And the pro-inflammatory phenotype had a lot of biomarkers, IL-1, all the inflammatory biomarkers were higher in those patients. They had higher levels of acidosis, high levels of protein C. They had increased mortality, much worse lungs, and the decreased ventilator-free days. In them, so if you look at this, the ones with inflammatory the low inflammatory hyperinflammatory subphenotype, the mortality overall was lower, but in them high PEEP actually had higher mortality than low PEEP. But in the ones with the inflammatory phenotype, though they had a higher mortality overall, the ones when you use high PEEP had a lower mortality than ones when you use low PEEP. So this is one way maybe, but of course doing it phenotypes and finding out whether pro-inflammatory or not, maybe in them you can use higher PEEP, in the others you can't. This is one more way. Honestly, like I said, there is no, at the moment, nobody knows. So once you decide you're going to use PEEP, how do you titrate? How much PEEP to give? 10, 15, 12, what, how do you do? How do you titrate your PEEP? Like I said, again, ESICM, again, backing out, saying nothing. We're unable to make a recommendation whether you go by mechanics or you go by compliance, you go by oxygenation. They say you can do whatever you want. So they're playing it very, safe. They don't want to make any recommendation. They said we're unable to make a recommendation for or against PEEP, guided by either mechanics or by PA to FR ratio to reduce mortality. No recommendation, again, no effect. But again, the Americans, again, a little more pragmatic, and they said a reasonable approach of patients with severe ARDS would be to use a higher PEEP strategy, but you titrate by oxygenation using either a PEEP FI to table or you titrate to the driving pressure. So till you get a safe driving pressure, you can use this. But obviously, the person at the bedside should be a little aware about PEEP. And most important, you need to measure the mechanics, measure the compliance. And most important now is it's been found that high PEEP, though it might improve oxygenation, actually can cause what's acute cor pulmonale. When we normally talk about acute cor pulmonale, we talk about pulmonary embolism. But even high PEEP can increases RV afterload and cause RV dysfunction and cause hypertension. So though it might improve PEEP, it might actually reduce cardiac output. And ultimately, we want better delivery of oxygen to tissue, not just high oxygen. So even though it increases oxygenation, if the cardiac output is falling, delivery of oxygen to tissue, ultimately PEEP is going to do more harm than good. So you need to monitor. And if one clue is that if you're using higher PEEP and the pulse pressure variation or the stroke volume variation increases, it's one clue, and that doesn't respond to fluid. It's one clue that maybe your PEEP is causing RV dysfunction. Maybe you should back off on the PEEP, even if the oxygenation is better, because it's causing. Of course, you should do an echo. But now everybody has an echo at the bedside. You can always look at an echo at the bedside serially to see the effect of your setting on RV dysfunction. The other method that you can use is what is called the stress index. Now, like I said, all these methods have been suggested, but there's been no study that shows that any one method is better than the rest. That is why people do what they want, whatever they're most comfortable with, but there is no evidence that one method is superior to the other. So you do what you are most comfortable with, and nobody can say that you are wrong. So this is called the stress index. Again, though it seems very simple, basically you put in volume control ventilation and look at the pressure graphic. So if it's a straight line, it's called the stress index supposed to be 1. That means your PEEP is adequate. This is concave downwards. It means that there is scope for increasing the PEEP further. It's called the stress index is less than 1. And if it is concave upwards like this, it means as you're increasing the volume, the pressure is increasing. That means here you need to come down on the PEEP. So this is called the stress index. Okay, stress index 1, which is ideal. More than 1, less than 1, you could increase the PEEP. Less than 1, you could increase. You should decrease the PEEP, particular tidal volume. So this is over distinction. There is more scope for inflating, and this is normal. So that is one way. Electrical impedance volumemetry I talked about, which will tell you the balance between recruitment and overwhelm distension, but it's a more expensive equipment. If you have it, fine. And of course, usable manometry is again. There was one study which showed that setting PEEP on the basis of usable manometry was improved mortality, but that was in one single center. But finally, multi-center studies did not confirm this that using usable manometry to set PEEP improves outcomes. But what was the principle of usable manometry? Is the concept of transpulmonary pressure that you should know about. Now, basically, we are not talking only about airway pressures. You need to talk about what is transpulmonary, because what really causes lung damage is not the airway pressure; it is the transpulmonary pressure. Transpulmonary pressure is the airway pressure minus the pleural pressure. That is why, in COVID, a lot of patients, why did they have lung damage? Because though the airway pressure was 30, they were breathing at a pressure of minus 15. The negative effort of breathing. So the transpulmonary pressure was 30 minus 15 is 45. That was causing lung damage. Conversely, if somebody has obesity or a thick chest wall or has got intra-abdominal hyper, where the chest wall compliance is quite poor, where the chest wall pressure is very high, there the transpulmonary pressure actually is low, 30 minus 15, because chest wall pressure is high. So these people actually can afford to use a higher pressure, you can afford to use a higher PEEP. So though routinely usable manometry may not be useful in the routine case, if you have a patient where you think the chest wall compliance is likely to be poor, like patients with obesity, patients with burns of the chest wall, patients with intra-abdominal hypertension, etc., they may be using PEEP guided by usable manometry might be useful. At the moment, routinely using usable manometry is not really going to be useful, but special situations, maybe when you think chest wall compliance is a problem, you might. Because like I said, somebody is having a thick chest, you set a PEEP of 15, but his chest wall pressure also is 15. So ultimately that means the PEEP is actually 0. In that patient, you can afford to use a higher PEEP. Then we come to recruitment. Now, what is the, basically by recruitment, you give the lung a sustained high pressure for some time, and then you bring the pressure down. What is the logic for this? Because this basically, this is called hysteresis. This is the inspirative limb of the lung PV curve, and this is the expirative. There's a difference between this. They're not the same. So why is this? Because this shows that it takes a lot of pressure to open up the lung. So here, see, the lung doesn't open up till you keep the pressure to 16. But once you kept it open, even if you bring the pressure down to 4, the lung remains open. That means you require much higher pressure to open the lung. But once you open up the lung, you can keep it open at a much lower pressure, because initially to overcome surfactant, etc., you require a much higher pressure. That is why this graph is different from this graph. They're not the same. They don't overlap. It's called hysteresis. So this is the basis for a recruitment manual, that you give a high enough pressure to open up the lung, and then you reduce the pressure to keep the lung open. Obviously, you can't keep them at 30, 40, but even if you bring the pressure down later with a reasonable PEEP, you could keep the lung open. That was the whole basis for a recruitment manual. So the logic was that you initially open up the lung with there are different methods that you use. Either you use a CPAP of 40, the classic one, a CPAP of 40 for 40 seconds. Now, recent studies have shown that most of the recruitment happens in the first 10 seconds. Beyond 10 seconds, it actually causes no more recruitment, but actually causes more of hemodynamic instability. So maybe if you want to give a CPAP 10 to 15 seconds enough, giving the conventional 40 for 40 seconds probably is going to cause more hemodynamic instability. The other method was to keep increasing PEEPs by 4 or 5 till you get a high enough. So prolonged recruitment manuals means subjecting the lung to a pressure of more than 35 for more than 1 minute. That was definition of a prolonged recruitment maneuver. And now studies have clearly shown that using prolonged recruitment manuals, have clearly been damaging. Most of the time, the damage is because of hemodynamic instability or sometimes barotrauma. So these are the two major problems. So clearly, prolonged recruitment maneuvers are out. Again, obviously, like I said, the ESISM recommends against everything. They said no, nothing, no prolonged. Some people are questioned whether you can use, like I said, use the CPAP for 10 seconds, not not a prolonged one, but a brief recruitment maneuver. At the moment, there is no evidence that it does harm, but nor is there any evidence that it does any good. So, but if you're desperate, you could probably try a recruitment maneuver. Especially this happens, quite often. I'm sure you have seen patients transferred from other ICUs during transport. Usually there's disconnection, and usually when they come to you, they say when they phone you, they say the FiO2 is 50% or 40%, and when it comes to your ICU, is already on 100%. So something has gone wrong. Most of the time, it's probably some disconnection, which means there's been de-recruitment. In those or sometimes for suctioning, somebody is open suctioning, the de-recruitment. Though those situations, probably giving a brief recruitment maneuver is not harmful. But like I said, maybe just 40 seconds of CPAP for 10-15 seconds is enough. 40 centimeters of CPAP. We don't really have to give a prolonged recruitment maneuver. That is the issue, that prolonged recruitment maneuvers probably cause though it might open up the lung, it has more barotrauma, more hemodynamic instability, maybe. And at the moment, in the exam, you have to say neither prolonged nor brief are recommended. But in practice, maybe in desperate situations, a brief recruitment maneuver may not be such a bad idea. Prone positioning, I won't talk too much about because I think there's going to be a talk about that. But basically, what prone positioning done is that basically, when you're in the supine position, the ventral portion of the lung actually gets over distended, and the dorsum of the lung is actually collapsed under its own weight and under the weight of the heart. And actually the area which is the best perfusion is got the worst ventilation. But when you turn them prone, the dorsum of the lung also gets opened up, so you're matching ventilation and perfusion. That is the whole basis of the prone. You're matching the area, because even in the prone position, the blood flow remains best to the dorsum of the lung. Though the ventilation changes, the blood flow remains the best. So basically, by turning the prone position, you're making sure that the area of the lung which gets the best perfusion also gets the better ventilation. So you're just trying to match ventilation and perfusion. Also, you're preventing over distension of the ventral area. So you're not causing, on one hand, you're preventing over distension of the ventral areas, not causing too much of damage. So that's the whole idea of a prone position. But there'll be another talk on non-ventilatory strategy. So this is a non-ventilatory strategy. Somebody else will talk about that. So I won't talk too much about proning. But you need to know, there's enough videos about how to do it. So I think it's not too difficult. Most people are still a little scared of it, but there's no need to worry too much. Even NMBAs I won't talk about, because there's a thing. Then about driving pressure. Now, like I told you, the main thing is in ARDS, ultimately whatever we use is not merely the oxygenation. What you're really worried about is preventing lung damage. Now, this concept of driving pressure talks, so we all talk about low volume ventilation. Of course, we say we'll use 6 ml per kilogram. But now, we know in ARDS, basically only about roughly 1/3 of the lung is normal. The rest of it is not functional. So whatever, tidal volume delivering, you're delivering to the so-called baby lung. We know all that. That's a baby lung. Now, even the baby lung, but the amount of lung that is normal in patient ARDS varies. It's not the same. For example, if you deliver, a tidal volume of 500 to somebody with a FRC of 3,000, that is likely to be much more safer than delivering a tidal volume of 500 to somebody with an FRC of 2,000. So it doesn't depend. So what you are giving is not enough. How much you're giving is not, by itself is not enough. You have to depend upon what percentage of the normal lung are you giving. You understand, of the not normal lung, of that patient's FRC you're giving. That is what is going to cause. So though you must say 6 ml per kilogram, the 6 ml per kilogram in somebody with a very, very poor normal lung, with a lung which is even very, very small, even that 6 ml per kilogram might be damaging. You understand? So basically, they are trying to say the tidal volume as related to and as a fact, you can't say what's the compliance. The compliance of the lung is supposed to be a predictor of the volume of the lung that is normal. If the volume of the lung that is small, then the compliance also will be very low. If the volume of the lung that is normal is higher, the compliance will be a little higher. So the tidal volume delivering as a fraction in relation to the compliance, that is the driving pressure. The tidal volume of the lung in relation to the compliance. So that will tell you how much actually how much tidal volume delivering in relation to the compliance of the lung. That will tell you actually better indicator of the damage, potential lung damage, compared to just tidal volume itself. So this is why this is supposed to be a better indicator of lung injury as compared to merely tidal volume, driving pressure. I mean, the formula, like, how is it derived? Because if you look, compliance is equal to tidal volume divided by delta pressure, no? So you just exchange like you do in maths. Driving pressure comes this side, resist compliance comes down. So So driving pressure, so that is fraction of tidal volume as compared to compliance comes to is the driving pressure. That's the formula. Okay, that's so driving pressure. That's how is an inadequate, is a indirect indication of what tidal volume is giving as compared to the compliance of that particular lung. And this was a study where they looked at all the, this was a retrospective study. They compared all the large ARDS studies, and they looked at three sets. In one group, they kept the PEEP constant. One group, they kept the driving pressure constant. The other group, they kept the plateau pressure constant. And only where the driving pressure was constant, you can see the mortality was the same, more or less, as long as the driving pressure. So it did not matter whether the PEEP was high or low or the plateau pressure was high or low, but as long as the driving pressure was constant, the mortality was constant. And in other groups, even though the PEEP was constant, if the driving pressure increased, the mortality increased. And if the plateau pressure, what happened to plateau pressure? If the driving pressure increased, mortality increased. And when the driving pressure reduced, the mortality reduced. So on the basis of this, they propose that driving pressure is a bigger indicator of mortality than the tidal volume. So therefore, they recommend that you try and keep the ventilation with the driving pressure less than 15. Now people have tried to set PEEP to driving pressures. No study has shown again that a driving pressure based strategy has improved outcomes. But maybe still it's worth, looking at driving pressure, maybe it is worth trying to keep the driving pressure less than 15. Though I said that some people have set PEEP according to driving pressure. You increase the PEEP by 2, driving pressure comes down. That means that you can increase the PEEP further and all that. But that strategy has not been shown to be useful. But of course, in those strategies, people also use recruitment manuals. Maybe now you should do a strategy without recruitment manual, just use PEEP and see if maybe that might help. But theoretically, if you need to worry if your driving pressures are going up, maybe you need to bring your tidal volumes down. Even if it is 6 mmol per kg, maybe you need to bring it down even further. Now, to make even matters sort of a little more complicated or whatever, some people seem to say that it's not just the driving pressure, it's what is called the mechanical power. It's not just the driving pressure. It's not the only driving pressure which affects the lung. Power means the entire punch. The ventilator is ultimately punching the lung. Whatever you do, back and forth, it is punching the lung. So the power in everything that you do, when you punch somebody, the force with which you punch him, how many times you punch him, how much the patient moves, all that works. So basically, so they said mechanical power is a better indicator of lung damage as compared to merely the driving pressure. So for mechanical power, you need to cover everything. You need to cover the tidal volume, the peak pressure, the driving pressure, and the respiratory rate. And there's this complicated formula to cover to look at mechanical power. But basically, this study showed that the higher the mechanical power, the worse were the outcome. They looked at 2 studies, and ICU mortality 30 month 1 year, all was higher in patients with a higher mechanical power. So they said that mechanical power is actually higher mortality. Impact is consistent, independent presence of ARDs of the use of NMBA. And even at low tidal volume and low driving pressures, high mechanical power should worse outcomes. That suggesting that mechanical power, so they say now you look at mechanical power, don't look only at driving pressure. But now it's difficult at the bedside for all of us to calculate mechanical power. So these people have now suggested even a simpler formula. They have said mechanical power, ultimately, you just look at 4 into delta driving pressure plus RR. That's it. That is a better indicator. That's as good as mechanical power. So you look at some outcomes. When you looked at this as an indicator of power, the outcome was almost the same or probably better than whole mechanical power. So they say that you don't need to calculate a more complicated formula. Just look at 4 into driving pressure plus RR. Basically, what this tells you that now, see, we always have this problem. You use low tidal volume, CO2 goes up. So do you increase rate or you increase? You increase your rate or you increase the tidal volume. Now, if you increase, so basically what it says, each time your driving pressure increases by 1, that's like increasing the rate by 4. You understand? Because so you have to do you see in your patient, when you increase the tidal volume, the driving pressure goes up much more. And you do, so what they have as a general rule in patients with a low compliance, poor compliance, very stiff lungs, probably better to use a higher rate than to increase because in them, even one slightly increase in tidal volume will cause the delta pressure to go up much more. In patients relatively better compliance, maybe you could use because use a lower rate and a higher tidal volume because the driving pressure won't go up that much. So, but generally in the very stiff lungs early on in ARDS, maybe it's better to use a higher rate and a lower tidal volume, which is probably why in the ArchNet they use high rates, even the CO2 vendor, maybe that's why the outcomes are good. One of the reasons. So this probably now this is the latest concept that this formula is probably very simple. So that's how maybe you can set your balance between driving pressure and your rate and tidal volume. And finally, of course, if everything else fails, there's ECMO. Now, of course, ECMO has its own problems. It's not, not the ultimate panacea. Every hospital in the city now wants a ECMO. Ideally, actually, it's a waste of resources. It's too expensive. Ideally, everybody should pool the resources. Unfortunately, ego problems. Everybody wants their own ECMO machine. Theoretically, it's an expensive device, and ideally it should be shared. But nobody wants to share that. They will all want their own ECMO. But I'm not saying ECMO has its uses, but you should know when to use. But ultimately, before that, what are the indications? Are basically less than 50 for more than 3 hours, less than 80 for more than 6 hours, or severe hypercapnic respiratory failure. These are you should consider treating. Of course, there are studies, the Caesar study. And Caesar study just showed that shifting them to an ECMO capable study had better outcome. Basically, maybe those people are better able to deal with severe ARDS. It didn't show the ECMO improved outcome. It showed that shifting to a ECMO capable center had better outcomes. The second study, of course, the Eolia study, there again there was no difference in outcomes, but of course in the Eolia study there was a lot of crossover. Almost 30% of people from the conservative people crossed over to the ECMO group, which is why you could not make any kind of record. But most people would, on the basis of this study, would recommend maybe ECMO in refractory ARDS. But you know, you don't have to be really, you could probably before that. Now especially, I think especially with proning, I think I'll talk about proning. Maybe if you try proning properly, probably in many patients you might be able to avoid an ECMO. Not everybody, of course, some of them do need an ECMO. Thank you.